So I'm Meredith Saillant. My esteemed colleague, Dr. McGrath, and I, along with Lisa Paredes, actually have worked on a project with Brookline. That's how we all got to know each other. You will find out very shortly he's smart, much smarter than I am. However, I am a primary care pediatrician in Brookline, and I've been asked to speak to you today about what you can expect from me when your athletes or your students or your patients need to come see a primary care specialist. So I'll do my best to give you an idea of what that's like, and then Dr. McGrath is going to speak about what happens when kids go see specialists. All right, so this is really, all right, so we are all here to talk about concussions, obviously. This is a great place to do it. I feel very honored to be here at Gillette with all of you. I don't know if that's on, but okay. So our objectives today are, we have about 5 things we're going to talk about. One is to, like I said, talk about what I do as a pediatrician when a patient comes to my office suspecting or having been diagnosed with a concussion. Then why I would defer my management out of my office into the office of Dr. McGrath or really end up needing his help, and it's a great resource for all of us. And then, if we have time, we're going to hope to talk to you about a little bit about return to play. And I know there's a little bit of overlap in the talks, and hopefully that just helps to consolidate information for you, or cement information for you, and not bore you to tears, but feel free to let me know if you're bored to tears or to me. I don't know this time. Okay, so all of us have a little bee in our bonnet about certain things about various people say certain things, and my little tiny bee is about ER utilization, emergency room utilization, imaging, use of ambulances, etc. So I just want to take 1 second to talk to you guys about the fact that most mild traumatic brain injury, which is really what a concussion is not an emergency. So when a child has a hit to the body or the head and we suspect a concussion, whether it's during sports or not, anxiety levels ratchet up. The child's anxiety, the parents, the coaches, the trainers, players, other parents or other adults in the field, and everyone very nicely usually goes to the child and tries to give their opinion. Some people say you must get a CT, you must get an MRI, let's call 911. I think that everyone here, I hope when you leave, you can all kind of have a little bit of calm, knowing that you can take a measured approach to most children, and really take the time to assess them before you kind of pull out your cell phone quickly and call 911. Just calling an ambulance and having them arrive on the scene costs over $1,000. Sending to the ER, if they end up going, costs obviously many more thousands of dollars to the healthcare system, and then at least hundreds, if not thousands, or more, depending on their deductible, to parents for just their copay of going to the ER. So keep that in mind. Most kids can, if you suspect a concussion, obviously we return them from the field. Remove them from the field of play, and they can be told to go home and rest and just follow up with me or someone like me. I would be remiss if I didn't say there are some kids who do need to go to the ER or need more urgent evaluation. I think we all kind of know what these reasons are, but prolonged loss of consciousness over a minute or so is kind of a rough guideline. There's no real data to suggest one time frame is worse or better than the other. But by the time anyone who needs to get to the child has gotten to the child, if they're still unconscious, then you need to think about how long it's been. A minute. You really have to worry. And then obviously a kid who has an injury and their mental status, their energy level, their symptoms just go downhill from there. Their headache gets much worse. They seem like they're super sleepy. They can't move part of their body. Those are red flags and reasons that you really should use that 911 system. How we approach kids. Okay. So, I get a lot of calls from the sideline. I get a lot of calls from home. I get a lot of calls the next day describing what happened during sports or otherwise. And So when people call me or when they show up in my office, I kind of do a quick run through of what happened. And what happened is really important with diagnosing concussion. So for me, kids don't always come to me with a diagnosis, right? Sometimes it's really obvious, but I sometimes have to tease apart whether or not they actually were concused. So I always do the red flag thing first, make sure the kid looks like him or herself, maybe feeling that yet, and I don't have any acute worries that I need to actually send to the emergency room immediately. I get a history of the injury, what the child was doing, if there are any witnesses, what they saw, what the child experienced both before, during, and after the hit. That can give some information about whether there was loss of consciousness, when the symptoms started, what the child has been experiencing since then. The timing of the symptoms, most symptoms develop within the first few hours of injury. Every now and then you'll see a kid who goes to bed after a late game, felt kind of fine, and then woke up really feeling sick, or like they're concussed. But usually kids will go to bed that night not feeling like themselves, and it's pretty obvious. We also see kids who felt not very good right after, and then quickly got better. The next morning they're better, the next day, the next week they're better. And those kids probably didn't actually have a concussion, they probably just had the effects of having hit their head, which doesn't feel very good. So we have to tease apart those things. Obviously, I'm a doctor, so I do an exam. I do a focused neurologic exam looking specifically, obviously, for about strength, the neurologic function, and then their balance. Their balance is really important. Most kids have pretty good balance for their age, but we can assess that in some standardized ways that I'll get into in a second. So if I see a child and think that it's a pretty good likelihood that he or she has had a concussion, I will give a standardized form called the Post-Concussion Symptom Scale. And that really, okay, I'll talk about that in a second then. And I also do the BEST, or the Balanced Error Scoring System. So these are two standard things that we can do in the office to compare kids the first day, the next week, and the next week, and until their symptoms have resolved. And they will allow us to kind of figure out that their symptoms have resolved. And I'll talk about those more in a second. So this is just a snapshot of an algorithm that I've been working on with some colleagues over at Children's in an attempt to standardize the care that is given across the community. So it's with an organization called the PPOC, or the Pediatric Physicians Organization of Children, and we are basically the people in the network for Children's. And there are well over 100 physicians in Eastern Massachusetts. And so with this, that we're going to be launching next month, we're going to try to take some of that variability that you guys might see, and that I particularly see when I cross-cover patients from other practices or have my patients covered by someone else when I'm not available. The variability that we see in the management of concussion acutely, and then even long-term. So just to give you an idea, we talk about that thing up there says initial contact, which I already talked about, red flags, yes or no, and then kind of what we do. And we're hoping that this system will become part and parcel of what people do every time they see a concussed child. And it's many pages long, and it goes through weeks and weeks of testing and weeks and weeks of visits and follow-up, and explains how we can manage them in the best way. So coming soon to a doctor's office near you, better care. Yeah?
When you say child, I'm looking at, it says 6 to 21 years. Is it the same sort of treatment? Is that how you're referring to the...
Yeah, so the reason we have, this is because an algorithm has to have like whom you include and whom you don't. And these are just typically aged kids, in school up to adulthood, basically. I'm sure you all know that the adult brain doesn't really form until kids are about 22 or so. So this is really specifically toward children. And then we have, some exclusion criteria, and those are just details for the clinician to kind of know when to use it and when not to use it. But the point that I wanted to just say is that as concussions emerge as an epidemic, really, and as we all are more and more mindful of diagnosing them and treating them with caution, it's important that we do it the same. We have algorithms and clinical practice guidelines for all sorts of medical conditions, and we're trying to do that for community doctors for concussions as well. Yeah.
Sure. Is your approach, I don't know, approach is very generic, and
yes.
And many of of the injuries in school are not related to sports.
Sure.
And,
Oh, yeah.
and you follow this sport.
Oh, yeah, so
Yeah.
the question is, does it matter if it's a sports injury or not? And the only reason I'm talking about sports injuries is because I'm here, but Dr. O'Brien and I once shared a patient who had a concussion from rolling over in bed and hitting the headboard. So I take all sorts of injuries, yeah, makes my job exciting. Okay, so if a patient I think has had a concussion, I will administer the post-concussion symptom scale, or PCSS, and this is an example of some of the things. It's a multi-step, it's a Likert scale of 0 to 5 or whatever it is. All these different symptoms that children may experience. Now, it specifically talks about children experiencing these symptoms after their concussion. So you're going to have kids who have headaches that they have to really try to tease out if they're worse or the same as before, their head injury. Kids who maybe have some chronic nausea or some belly aches, and things like that. So that does become a little bit complicated, but typically an average child should score 0 on the post-concussion symptom scale. If you take someone who's not had a head injury, so if anything is positive on this, it does raise an alarm bell that there has been a concussive hit. So we give it just 12-year-olds and older do it on their own. They can talk about their own symptoms on their own, and then for the little guys under 12, the patients and the parents do it together. And like I alluded to before, we use this every single time the patient comes back. So if the patient has a follow-up visit, hopefully the next week and then the week after, we can follow how their PCSS scores go and try to help give us some information about their recovery, which is useful. The other little standardized testing tool that I use is the BESS, the Balance Error Scoring System. I would say it's easy to administer, but I would say that not all kids, even kids who don't have concussions, can usually do it really well. I've been doing it in my office for a while, just on normal kids, and I wouldn't say I find it particularly 100% foolproof. But a typical kid is supposed to be able to do these stances, and I'll show you. I make sure my kids wear heels while I do it in my office as well. But so it's really about their balance without using any visual cues. So you're just using your vestibular system. So I'm closing my eyes, have my feet together, my hands on my hips, and it's supposed to be that I can do this for 20 seconds. Now, I really can because I practice it all the time with my patients, but some kids, like I said, can't do it. And then the next one is taking your non-dominant foot and putting it on the ground, holding the leg up, and then arms on the hips again, and then closing the eyes for 20 seconds. And any kind of breaking of the plane is called an error. And the last one is taking your non-dominant foot, putting it in the back, and your dominant foot in the front. Heels don't help. And then doing the same thing there. So we test that when kids come in as well. So that's a nice way to kind of see what their balance is like as an indicator for what their brain is doing and how injured it is. Okay. So if a concussion diagnosis is made, and we're all assuming it's going to be, I give the family information about the concussion and kind of a plan on what to do. So I have a parent handout, which I should have put it in the slides, and I apologize, but a parent handout talking about really basic explanation of what a concussion is, really nothing they can't find on the CDC website or somewhere else, but things that I want them to know because they can find things on other websites as well that I would prefer they don't believe. Frequently asked questions, what to expect, which I think is really important in pediatrics, particularly any medicine. It's important to give anticipatory guidance. So there's a huge range of what kids can experience after concussions, and I really like parents to know. They might get irritable, right? They might sleep a little bit more. They might be more hungry. They might complain of headaches never for 4 days, and then all of a sudden have one on the 5th day. So all that stuff is important to know so that parents don't panic, or that they can really appreciate what the child is going through and attribute it correctly to the concussion or not. So I give that. I also give a letter to the school, which will outline some of the stuff that's coming down. And then I give parents a plan of action. So there are really 2 things that you probably have heard already this morning. Physical accommodations, removing everybody from sports and exercise. So that's not just their physical contact sports, but everything. So runners, cross country, swimmers, bikers, walkers, speed walkers, anybody, badminton players, they really should just stay away from all sports for at least a few days, if not longer, to avoid not only another blow to the head while they're vulnerable, but also to avoid stressing their system. So we know that the mechanism we think isn't completely understood, but by using big muscles to exercise, you're taking away energy and glucose to the brain, and therefore slowing the healing. So we're trying to get kids to rest as much as possible with sleep, good nutrition, good hydration. I like to say rest, don't rust. I'm a marathoner, so as we do during our taper, we rest and we don't rust. So lay low, but don't do nothing. You don't have to sit in bed with the covers on and just listening to whatever, a book or whatever on tape for 5 days. You can walk around the block after a day or two. You can kind of maybe get on a bicycle and do some stationary biking to kind of get your legs moving, but not keep your heart rate up too much. And then cognitive reduction. There have been some recent studies that have shown that this actually is as helpful as we once thought it was, because it was in question for a while. But cognitive reduction, not cognitive rest completely, but reduction. So kids don't have to go into a black room, but they should not be going to school, at least the first day. Children's will say even 3 to 5 days long. Luckily, a lot of these injuries happen on weekends, and so they at least get a day or two off with that. And that means reading. Anything that's going to make them have to concentrate can increase their symptoms, and now we know that it really can prolong their recovery. If kids are doing better, so maybe not the first couple days, but once they go back to school, a reduced schedule at school is really important. So you can start off with half days. You can start off with a couple hours at a time, then go to the nurse's office and take a nap or rest, close your eyes for 5 to 10 minutes. If he or she will accommodate that in their office. Defer high stakes testing in particular, so if there's MCAS or SATs or even just a big exam in the classroom, that child should have that deferred. And then importantly, and also very, very upsettingly to children, screen time should be reduced. Now that doesn't mean they can't do anything on their devices, but anything that's high moving, high action, requires a lot of changing scenes and having their brain shift focus, we try to reduce for at least the first few days. Kids who have really profound symptoms will really probably monitor that on their own, because it just doesn't feel good to do it. Yeah.
So I'm a school nurse, and I guess my question is so for the first day, do you say no screen time or some screen time, or does that really depend on the symptoms?
First day of concussion?
Yeah.
So honestly, I believe in full cognitive rest the first day or so.
Okay.
And I don't know that there's data to support full cognitive rest, but I think just don't do anything. Be bored out of your skull and just take them in. I mean, we know that if you do cognitive rest the first day versus the 10th day,
Yeah.
it's okay. You can still recover from that, but that's 10 days where maybe you could have felt better. So I think why not? If you're going to be home from school anyway, just don't do anything. And if kids don't like it, they want to be on their devices and all of that. I don't think a couple of texts here and there are a problem, but they don't want to be playing video games or watching action films or whatever all day long. So I think from your perspective, I think you should recommend they don't have any screen time.
And just one other question. You had mentioned a little bit earlier, if so I had a scenario where a kid at recess ran into a pole, and then a few minutes later came down to my office. It was complicated because the kid could be a behavioral kid, so there was no lump, no bump, no sign of anything, and then he began to report symptoms. So I sent him home, and he went to the pediatrician, and it was really hard to tease out what was, what was
baseline personality.
Yes, and what was him trying to get out of stuff versus, what the actual injury was. So that's sort of one question, and then the other question is, you mentioned something about if they go to sleep and then wake up the next day and feel fine and like themselves. You said that most likely it wouldn't be a concussion, is that correct?
I mean, it depends on what their symptoms are that first day. If they're minor and they woke up and they feel totally fine, I think you could manage them like they probably did not have a concussion, unless they lost consciousness or
Right.
they, were really, really sick. But if they had an evening where they just felt a little, like they had a little headache or something,
Yeah.
and then the next day they were fine, I think, I don't know, fair in saying that, or?
I would say headache alone, localized pain alone, as soon as we start seeing
Dizziness and
other symptoms,
Yeah.
even on that first day, then I would say we usually it's better to treat it conservatively.
Yeah.
And not find out that, when you're pushing the person too far in the next couple of days, or heaven forbid, they're back in contact sports at that point. But, that may be the concussion that's resolving really quickly.
Yeah, I mean, if they really are feeling fine, you can
Right.
do that, you can go forward.
So that could be considered, I guess it's hard for me to say when is a bump on the head or a jostle on the playground, a jostle, and when is it something more?
Usually it's symptoms. I mean, you really, mechanism is huge as well.
Yeah.
You can use your judgment about that. I mean, the kid that rolled over in bed and hit his head on the headboard, it took me a while to really consider that a concussion, but it truly was, and baffled us all. There's probably some substance involved. But no, you can use, I think you can use your judgment, and then just let the parents know. I mean, you're in a great position. You're not the one that has to really make those decisions, but you're on the front lines. You have to filter them out. So I think if you put that on the parents and say, I want you to talk to your pediatrician, that's a good starting point. And then your other question actually segues really great into Dr. McGrath, because there are kids for whom you just can't tease out behavioral or baseline personality stuff from what's going on, and they are complicated. And those are kids that are also excluded on our algorithm. So kids who have any neurologic problems, even kids who have ADHD, sometimes we can't really treat it with the same mindset. You have to kind of take them into different consideration. All right, so, and then last, just bringing what you said, what we do, it has to be a real cooperative effort between the parents, because the parents have to be on board. The little kids, they usually move on with the parents, but the older kids will do lots of things to try to undermine, or in one way or another, their care. The physician, obviously, in the school, so everyone needs to be on the same page. And then I want to kind of race through this. I want Dr. McGrath to have time to show you how smart he is. After the initial recovery period, so I follow kids up once a week, either by phone or in person, and once they're doing fine, and then we do the PCSS and VES again, keep doing it until they are feeling better. And as they start to feel better, we'll do return to school, return to play, advancement, which we'll talk about in a minute. Now, most kids will feel better in like 7 to 10 days, maybe 2 weeks, 3 weeks, fine. There are kids that just don't feel better. They have a lingering headache, they are irritable, even if they're back in school, they just can't make it through a full day. There are kids who are complicated, they have predisposing conditions to make them complicated children to begin with. So those children particularly, and sometimes even the really complicated kids who've had multiple concussions or are on multiple medications, or who have a lot of learning disabilities, but some tricky behavioral things, those children, as well as children who've made it to like about 4 weeks or so, 3 to 4 weeks without complete resolution of their symptoms, I will call Dr. McGrath or children's or people at Mass General to try to have them help me tease it out, because I'm just not that smart. All right, that's about it. So I'm going to turn it over to Dr. McGrath, and take the field.
Okay. Okay, thanks.
We turned it off while she's gone. Oh, it is on. Because we're not doing any of these on.
Are we good?
1 second.
So, my hope is that every kid who sustains a concussion is lucky enough to see a pediatrician like Dr. Saillant. One of the things we see as specialists all the time is, and I'm sure every speaker here today will agree, there's just a wide variety of expertise out there among emergency room doctors, pediatricians, primary care doctors, and others regarding what we think is a concussion, what is not. A lot of the trouble we'll see as a specialist is that student athlete or student who's been concussed some other way who wasn't managed correctly to begin with, where complications occurred. So what we're trying to talk about today too is this partnership that we hope is always there between the pediatrician and primary care doctor who knows what Dr. Saillant just reviewed with you and takes the child through that. And as she said, most, by the numbers, the largest numbers are going to be recovering quickly for us. if you spend time in practice with myself, Dr. Allie Jackson, who's here with me, you'll see that our practice looks a lot different than the better in 2 weeks, because we're where everyone comes who's not better in 2 weeks. But in talking about a specialist evaluation, let me make a few points. There are different kinds of specialists when a child is not recovering too quickly. And I think the referral has to depend a lot on what the nature of the issues would be. Medical issues, sometimes kids need to see a neurologist. Sometimes the focus should be headache evaluation and treatment. Sometimes there are sleep problems that need to be addressed. There are medications that both primary care physicians, but particularly specialists, can start to bring in to help with those conditions. Where we neuropsychologists come in are particularly around the issues of academic functioning, cognitive ability, and behavioral emotional issues. Now, in thinking about the work that we undertake as specialists, I want to go back to a basic definition of concussion, which reminds us that the symptoms we're going to see are in different domains: physical, cognitive, emotional, and sleep-related. Recovery is a sequential process that takes place over time. And in some cases where we're involved, that time is very extended, months and longer. We can think about the symptoms again in these 4 groups, and what's important to remind us that we're reminded about in this slide is that there's an interaction very often among the symptoms that people are presenting with. You know, that trouble sleeping can exacerbate headaches. The headaches, people will say, I'm not falling asleep because my headache is too bad, or I'm more irritable because I have headaches, or because my mood is disrupted, or because I'm light and noise sensitive, that makes my mood worse. So we have to appreciate not only the range of symptoms and the intensity, but how they affect one another. And to think about these symptoms for a minute, and again, there is that issue we hear again and again, you know, is a bump on the head a concussion or not? And I would really agree that it goes back to saying you've got to do that initial symptom review. If it's a headache alone, localized pain alone, probably not a concussion. But let's think about the other symptoms that could come along in that parade. Headaches are certainly the most prominent, well-known symptom in concussion, often the first thing to appear and the last thing to clear. But we'll see fatigue and tiredness, dizziness that is often characterized as coming on with positional change or movement. That could be vestibular, it could be related to changes in blood pressure regulation. Nausea, light and noise sensitivity, or ringing in the ears. And again, when you have these, they in turn interfere with your focus. They often increase with cognitive effort. The kid who's back doing too much in school finds that it actually makes them nauseous to study too long, or it makes a headache worse. The second domain, cognitive, the key issue here is trouble with attention and concentration that feels to students like problems with short-term memory. I read something over and over and it doesn't stick. I'm having trouble focusing, I'm not registering the information. We'll see slowed thinking, and the word that comes up over and over for concussed patients is foggy. Think about it. You don't hear people talk about foggy unless you're drinking heavily or unless you've had a concussion. And if you hear that word, it should catch your attention. But these cognitive issues affect someone's ability to follow in class, to do homework, that rereading we talked about. And again, students will be in class, they'll be dismayed to find that they thought they followed and listened, but they're home that evening and nothing is really carrying over for them. The third domain, sleep difficulties, can involve falling asleep, trouble with overnight awakening. Basically, sleep architecture gets disrupted. And we know, as we heard earlier today, as soon as sleep goes, a lot of other things are automatically going to show up. Your post-concussion symptom score can raise by itself, as Dr. O'Brien was talking about. But this is an issue, sometimes melatonin, sometimes medication, sometimes implementing good sleep hygiene. But when you're not sleeping well, it makes the energy crisis of concussion worse. It further adds to your trouble with attention and concentration. You miss classes, it makes your mood changes worse, etc. Our final domain, mood disruption, we see irritability in most people, because if you've got 10 or 12 of the things we just talked about, you're going to be irritable, and your nervous system is simply less capable of handling stimulation. But when symptoms extend on for longer periods of time, we in some cases see the onset of anxious symptoms, of mood changes, as kids get worried about what's going to happen in school, how far am I falling behind, what do my friends think of me, and so forth. So, and again, these emotional changes can lead to complications as well. Now, as we've heard, most concussions recover pretty quickly. Here's data from one particular study that showed, football players, 80% were back to normal in terms of them not reporting any symptoms and their cognitive test scores looking back to normal within about 3 weeks. But we spent a lot of time working in this region out here with people who are not better. What are the risk factors for being in that group? The more concussions you've had, the more likely you might be having a slow recovery. We see again and again concussions coming too close together in time, especially if they haven't been identified and managed properly. So you take that careful history Dr. Saillant's talking about and find out someone hit their head in practice, a week ago. They had symptoms, they didn't report them. They're playing really concussed, and then the next hit comes along. And then things start to go downhill. And particularly that re-injury prior to full recovery. And we need to remember that when someone is symptomatic or in recovery, whatever the process is that's going on within the nervous system, too much physical exertion or too much cognitive exertion can cause symptoms to look like they're regressing and going backwards, going to a higher level, and really prolong the recovery. So the work we do as specialists involve really both intervention in the school level and in the individual patient management and family management level. I want to give a little background for a system we've talked about using in schools. And again, so many people are working these days to think about school intervention. You've got to think about a lot of different templates that people are bringing, and we'll talk about a few here. But everyone's agreed for years, you've got to start with education. When everyone involved understands symptoms and risks, and some of the issues we're talking about today, people make better decisions all the way along the line. Education is free online. Education is mandated in many places by state law now, Brookline Parks and Recreation, so on and so forth. But secondly, what we're able to do in schools these days is implement one of what we call the cornerstones of concussion management, which is cognitive testing. Now, there are several varieties or makers, you might say, of this kind of testing out there, but it can be used both for baseline measurement and for follow-up. You do not have to have baseline measurement to use this kind of testing for follow-up, because we neuropsychologists are used to doing that all the time. As I said, there are several different makers. The one I'm more familiar with is called Impact. And let me take you through it real quickly. How many people here are involved with using a system like Impact or ANAM or Cogstate in a school? About half of you. Okay. And a question?
I was just wondering if any of these would ever become to the point where you could have a child or a parent administer it at home and keep track of it.
We tend to advise against home administration because it takes it really out of the more controlled environment. We have many stories of someone who had their brother take it for them at baseline because they thought they wouldn't do well, and they didn't actually understand that the better you do at baseline, the harder it is to return later. The cat jumps on the computer screen. You've got bad internet connection at home. The stories I could tell. So we advise against home testing. There are some places in schools who try to do it, though. But again, concussion evaluation always begins and ends with understanding symptoms. So a test like a system like Impact starts off with having people rate symptoms. And again, some of these symptoms could be present in normal life, but you want to make the distinction, what kind of things do you normally have and what's different now that you've been injured. There's a test of word memory, a test of memory for funny shapes. There's a test of spatial memory that's interspersed with a speed reaction time task. There's another task where you have to both demonstrate your quickness in doing matching and then remember what number goes with what symbol. There's another test, which is a version of what we neuropsychologists call the Stroop test, that shows you a word on the screen. The word's either red, green, or blue. If it's in its own color, you click once as fast as you can. The computer measures you to within 1/100th of a second to see how quick you are. If it's not in its own color, you let it go. Another test where you're having to remember 3 random letters, and then while those letters go away and you have to keep them in your mind, you have to do a quickness accuracy task. Then you come back to remember words, then you come back to remember shapes. What comes out of this kind of testing, which takes about 20 minutes, are measures of memory and speed. It's not an intelligence test, it's not the MCAS, it's not the SAT. We're trying to understand the kinds of things that tend to be affected cognitively in concussion. when we're analyzing results, we look at a sheet like this, but really the simple concept is we're trying to understand how somebody would do in baseline and then progressively watch them recover in memory and speed and attentional function during their progression back to full recovery. Even when we don't have a baseline, we have norms like we do in every neuropsychological test tool we use to understand, someone might be a top A student, but they're performing in the lower part of the average range. We don't think that student's really up to where they ought to be. Now, again, when we think about neuropsychological testing as a part of the specialty evaluation, we can think about this at really 3 different levels. One is the screening level, which is using a test like IMPACT, which can be used in schools, which is used by athletic trainers and school nurses. We consult to a network of a few dozen schools, helping them understand their test results there. But when that's not enough, and when the pediatrician is saying this kid's not better in 3, 4, 5, 6 weeks, someone else should be taking a look at them, when they're coming to our office, we're thinking in terms of kind of 2 possibilities. Typically what we'll start with is brief testing I call partial serial assessments for these slower recoveries. What that may involve is 30 minutes to 2 hours of testing per visit, looking at things like, again, more in-depth attention and concentration, learning executive functions, processing speed, maybe reading comprehension and math fluency. It's not the total neuropsychological evaluation package you get, but what we're trying to do is repeat some of these test measures periodically during, say, several weeks or a few months of recovery. Now, for those students who are going on and now it's months and longer, we sometimes come to the point where, as Dr. Cantu mentioned earlier today, that's that student across the desk who is really not getting better anytime soon and who may not ever be getting back to their normal full potential. That's where we start to go to the more comprehensive battery neuropsychologists are known for, that can involve a full day of testing or a couple half days of testing. That comprehensive battery starts to look at academic ability, more in depth with learning, you get an intellectual profile, and it helps the school and the rest of the clinical team really be guided to say, where are the strengths for this person, where are the vulnerabilities, and then we can periodically repeat both of these kinds of evaluations over time to see what progress we really have. Now, while this kind of evaluation is going on, the key function for student athletes is not athlete, it's student. So our focus is how are we helping the student really readjust to the world of school. As Dr. Saillant said, and I tend to agree, a day or 2 or so off school for that really highly symptomatic kid, a great idea. You're not trying to lock someone in a dark room and saying you can't look at anything. It's that issue of relative rest, but erring on the side of rest at first is a great idea. And then it's really interesting as you work with patients to hear all the time about what levels of physical and mental exertion cause symptoms to go up. It's a learning process and it's a little different for every student. But even if we're resting them from sports, from the academic and mental side of things, we can easily see that symptoms can be worsened with too much activity. So here's what we're trying to avoid. You remember Bill Murray in Groundhog Day. This was the movie where he's the reporter. He goes to Pennsylvania to cover Groundhog Day and finds he's reliving the same day over and over, and it's not going well. Well, eventually I think Bill solves it by deciding he's got to do the right thing to go after the girl. He gets her. But what we're trying to avoid is Groundhog Day for a concussed student athlete. Groundhog Day looks like this. You haven't slept well. You wake up fatigued. Your energy's low. You get headaches sitting in class. You can't follow what's going on. You feel worse as the day goes on. Light and sound bothers you tremendously in school. You can't be in the cafeteria or under fluorescent lights. You're really exhausted after school, but you feel like you have to go home and do homework. That makes you worse. You have an emotional meltdown and get into it with your parents or your brother and sister. You go to bed feeling worse and you sleep even more poorly as a result of all that. Too many kids roll into my office who are living Groundhog Day. And that could be because either no one's been at the helm to guide things, or no one's been listening to a doctor or someone else who's been at the helm trying to guide things. What we often see from the specialty point of view is when you break it down and ask about athletic activity, we'll often hear that kids may have specific issues. They may be able to sit and listen in English class quite well, or listen along in history class, but trying to perform math calculations may really make their head hurt. They may be quite good in a second language and currently find that their access to that language is much lower than they expect. And reading is almost always a problem because it's so multifactorial. It involves attention, concentration, visual scanning, memory. And usually one or more of those things is off for someone. We see often in reading a lot of trouble with visual function. Words seem to move on the page. People find their vision gets blurry. So when we think about the issue in school, I try to help school staff understand that what we might be dealing with is something like a learning or attentional disability, but instead of being developmental and permanent, it's temporary and short-lasting. We're still expecting a complete recovery for most every student. In some cases, a 504 plan is a good idea for a slow recovery. When you're really managing these well for most kids, if you do the right things in school, you don't even need to spend the time writing a 504 plan. But for, again, the student who's slow in recovery and going on months now, that may help line things up. So again, we have to revisit. Dr. Saillant mentioned the kinds of accommodations that are recommended early on, but when it's a slow recovery and we're dealing with the fact that things aren't getting better, we have to go sometimes more in depth to think about exactly what's happening in school and not happening accommodation-wise. How much can someone be attending school? Is partial attendance a good idea? The person who doesn't sleep well may do better to stay in bed in the morning and hit the classes for the afternoon, or vice versa. Rest periods during the school day are one of the most important things. Getting out of class if your headache gets too big, getting down to the nurse's office, resting up there. The most important thing classroom teachers can do is extending assignment deadlines to remove that pressure. You know, so many kids get freaked out that they are starting to fall behind in school rapidly. I remember when my boys were in high school, we had the bright idea to stay an extra day on a vacation and come back two days late to get started after school break. And our sons didn't let us forget about that for months in terms of how far they felt they fell behind in their classes at school. Now, and particularly the higher caliber the student is, the more responsible and worried they get about that. So taking that pressure away. The younger the student, the more we encourage everyone to relax a little bit about reducing the workload, not make a student make up every last thing that's been missed. You certainly don't want a concussed, symptomatic student pushing ahead too much with quizzes and tests. Now, I know our time is limited, so I'm going to fast forward through a few other accommodation ideas. Did you know wind instruments can cause symptoms to get worse if you try blowing a piccolo or a tuba? Bottom line is, in this accommodation process, it's a team effort. Reply all email is a great thing to keep everyone on the same page. Feedback from home back to school, from school back to home. I tell students to check in daily with your nurse or guidance counselor to make sure you've got a point person at school. And it's really a team effort. Every accommodation plan turns out to be kind of a work of art that individual school, student, and family craft, and it's evolving and changing. What are we looking for to get someone back? They're fully symptom-free at rest. Any cognitive testing we as specialists do look back to normal for them or back to baseline. School looks back to baseline for them. They exercise and they get more vigorous with exercise. They remain symptom-free. And then something we do in our office is also check and see what cognitive function is doing once a student is exercising. We've got data that shows that not everyone maintains strong memory performance once they start working out. We want to make sure they're not getting hit in the head under that condition. So Dr. Saillant and I wanted to go here at the end through just a couple of return to play, return to school issues. So first of all here, in terms of thinking about levels of returning to academic function, and Meredith, if you'd like to help comment here, why don't you come on over? Sure. Again, thinking about graded steps that students can move through heading back to school. Because again, I just spoke about thinking about individual symptoms and accommodations. What a school staff often says is, that's a lot of information. Can you break it down into a simple stepwise plan for us? And here's one. So we'd be starting, with no physical or cognitive activity. Again, that early rest period, starting to gradually reintroduce cognitive activity, moving up to homework, but no testing, starting to get back to more school attendance, moving into full days of school, moving back to testing again. And often what it takes at the end of a process, if this has taken weeks to months, is a plan among the teachers to say, what are we expecting Mary or John to make up, and what are we going to be kind of, if you will, forgiving or reducing for them?
One important thing is if the child doesn't do well at one phase, they need to bump it back again, which is pretty obvious. But
Yeah.
So if the homework is too much, gives them headaches, or makes them too tired, then they need to go back to slowly reintroducing things.
Yeah.
So
And then,
kids can sometimes just barrel through the stages.
okay, and this, 6-step return to play really has to do with, again, physical exercise and return to contact sports activity. This is the same template outlined in, say, the Zurich guidelines and the NATA guidelines, really starting with no activity, working to light aerobic exercise. There's evidence out there now to suggest that once someone's over that initial intensive symptom hump, a low level of exercise that gradually increases may actually support rehabilitation. As you say, rest, not rust, and helping someone get back to exercise counteracts the effects that sudden deconditioning can have.
And it can reduce the anxiety and the depressive symptoms as well.
Absolutely. Yeah. So again, this is that 6-step return to play. And something else that I always like to remind people is that, let's say you've got that student who now, after a period of time, meets all those criteria we just talked about. Does every student go back to play football right away or soccer right away? This is the table of modifiers from the Zurich guidelines that has a clinician think about, how long did symptoms last? How many concussions as a person has? Do they have comorbidities like ADHD or learning disabilities? Do they take medication? Were there seizures involved? Which sport are they going back to? How aggressively do they play that? And those kind of factors should come into play with the doctors thinking about, are you going to say that you go back to play right now in this season? Are you going to say you take the rest of the season off? Are you going to suggest that you not ever return to this sport? So not every recovery turns out to be equal at the end in terms of how we advise moving forward.
And I think that if a kid has had a couple of concussions, obviously we want them to be seen by a specialist, but starting to plant the seed that golf and tennis and swimming are very nice sports, and all of that
Yeah.
can
Yeah.
be helpful in the long
And
run.
something I'd add to that too, in terms of the psychology of working with student athletes, is I try not to think more with them than a season at a time. When I start to talk about, you may not be back to football ever, the conversation, I think the listening shuts down. And when we talk about what are we going to do for this season? I had a kid in the office this week where we were able to talk about no more lacrosse this season, and let's not do contact over the summer, but a lot of conditioning, and let's see where we're at in the fall. And that's about as far as I've been able to successfully extend a horizon before an athlete starts to kind of shut down. And who knows, when we're in August, what the conversation's going to be at that point. Maybe symptoms have come back. Maybe someone's doing real well. Maybe they've decided not to play football at that point. So I think that's what we wanted to cover today. I know we're a little over time, but probably time for a couple questions.
The 6 steps, wonderful. Where would a school or system or somebody find that easily?
If you look at the Zurich 2012 guidelines, or I believe the latest NATA guidelines just published this year have them, but Zurich 2012, if you Google that,
What
you'll get
school
the...
system do you work in? So you should talk to your, the education department, because some towns, Brookline in particular, that's where we work, we have one that's at the high school level. It's like a maze to get through it. It's really complicated, but it's really nice to have a standardized form. And at Brookline High, at least, you can't, there's like your green level, I don't know what the levels are, it's like green, yellow, red or something. And you have to go through in a stepwise fashion, and there's specific parameters on those different levels.
Yeah, you
And
can
it's
have
really
that.
helpful.
Yeah.
Oh, they do in the high school? Oh, okay. Well, you can modify it down. And that's part of what this plan that I'm Mansfield Pediatrics and a lot of those places are part of the PPOC, so we're coming up with handouts to give for these return to play things.
For the athletic ones, just so she knows, DPH website
Yeah.
has it on there. It's a much easier link sometimes because the Zurich are in the British Journal of Medicine, so if you don't have access.
Good, good.
Website should be there. Yeah, and your athletic trainer will have them because they have to follow due to the state law.
Good, absolutely. Thank you, Kathy. Thank you. Good. Question here.
I'm a nurse in a high school. What do you tell educators and administration when you have a student who has prolonged concussive symptoms and they're feeling like that they don't have enough grades or credits with the kid to move them on to, you know, their next grade or to graduate? Now they come to me looking for the answers, and we have the doctor's documentation that they're still like on reduced workloads and they're excused for excessive absences. What do I tell them?
Well, that's a tricky question because you got the intersection of what's best for the health and recovery of the student combined with the educators wanting to make sure they maintain standards. The older the student, the more pressure there tends to be around that. I mean, that's a tough discussion to have with teachers for a junior in high school who's in competitive application for colleges with other students. It's much easier to have that at 5th grade where everybody can relax a little bit more. One of the things we remind teachers about is the student can only do what they can do. And let's also think about, are we on course to pass the student, we think, with maybe outside work and summer work and tutoring, or are we looking at really having a student repeat a year, which is a major thing to have to do? I'll advise the teachers to say, let's think about what's foundational for the student. You know, math and foreign language tend to have more foundational material. In other subjects, you can be a little more elective and say, well, we'll let it go if you read, you know, if you cover this book and these 2 essays instead of these 4 books and these 6 essays. And again, there's a lot of modifications we didn't have time to go into in terms of testing accommodations, you know, evaluating differently. Instead of multiple choice questions, you allow for essay, or you allow an oral exam instead of a written exam. Something they can do off the computer instead of on the computer. But I mean, I think the goal for everyone should be, how do we allow this student, how do we support this student to move forward in their education, knowing that this has been a setback, that they're not taking all the information they would have had with them into the next grade. But we do everything we can to make it so that they can move along with their cohort instead of staying behind for a year. It's tricky. It's tricky. I think we should probably stop here. We're around if anyone has any more questions, but thank you very much.
I have everybody's CEU sheets back here in alphabetical order.
Thank you.
There are
Thank you, sir.
evaluations
It means
for
a
the
lot
entire
coming from
form
you.
and happy stuff. 40
No,